See that slide?
Yes.
So, yep, good. So I'd like to thank you for that introduction, and also to thank Dr. Gopinath and Dr. Priya Selvaraj, Dr. Nalini Mahajan, and the other members of the organizing committee for inviting me to speak to you today. It's a great pleasure and a great honor to be involved in this really important conference. So the focus of my talk will be on tips for perfecting vitrification. Firstly, I'll review the basic principles of cryopreservation. Then we'll consider how to manage expectations, the training process and evaluation of results using key performance indicators or KPIs implemented in your laboratory. I will go through traceability and witnessing as it's one of the most important topics nowadays. And finally, we'll discuss some of the tips that can help you improve your results. So let's start with the definitions and different applications of cryopreservation procedures in IVF programs. Cryopreservation is a process that allows us to stop cell metabolism by exposing them to high concentrations of cryoprotectants, store them at low temperatures, and thereby maintain their viability. Freezing and storage of human tissues and cells is carried out using liquid nitrogen at -196 degrees Celsius in order to preserve them for future use. At this low temperature, there's no physiological activity, so cells and tissues can be stored almost indefinitely. Cryopreservation is not necessarily an artificial process and can also be found in vivo. For example, this is a photo of an Alaskan wood frog, which can tolerate the freezing of its blood and other tissues. Urea is accumulated within its tissues in preparation for cold weather in winter. And in response to internal ice formation, liver glycogen is converted in large quantities to glucose. Both urea and glucose act as cryoprotectants to limit the amount of ice that forms and to reduce the osmotic shrinkage of its cells. The use of cryopreservation has increased over the last decade due to the implementation of various new approaches to IVF treatment. Benefits of cryopreservation include preservation of fertility prior to potential gonadotoxic therapy for disease, quarantine during infectious screening prior to donation, social convenience and preservation of oocyte quality when delaying fertility treatment. For example, we may have to cryopreserve oocytes until a later cycle of treatment due to unforeseen events, such as when a semen sample cannot be produced on the day of oocyte retrieval. Mostly, we cryopreserve embryos and blastocysts in freeze-all cycles, when we have surplus good quality embryos, and for temporary embryo storage while awaiting test results from pre-implantation genetic testing or PGT. Also, we now know that optimization of clinical outcomes can be achieved with more physiologically timed elective frozen embryo transfers. There are two main methods of cryopreservation of human oocytes and embryos that have been used in IVF labs for the past few decades: slow freezing and vitrification. Both techniques are based on the principle of dehydration. Slow freezing involves a controlled slow decrease in temperature with a slow increase in osmolality around the cells and requires a rate-controlled freezer. You can see the temperature profile of slow freezing in the blue line here. Vitrification allows the solidification of cells into a glass-like structure without forming ice crystals. Compared to slow freezing, vitrification requires a much higher concentration of cryoprotectants and a very high cooling rate, which can be achieved by immediate plunging of cells into liquid nitrogen. You can see the temperature profile of vitrification in the red line here. Although these two methods differ, they allow us to achieve high rates of cell survival and viability. Cleavage stage embryos can be cryopreserved with similar outcomes using either slow freezing or vitrification, but for oocytes and blastocysts, vitrification seems to be the preferred technique. Laura Rienzi and colleagues showed that the contribution of cryopreservation to the cumulative live birth rate in Europe in 2011 was around 4%. We can assume that this figure has increased in recent years because of PGT and freeze-all cycles. So the importance of an efficient cryopreservation program in the clinic is crucial, as it provides so many benefits, such as time for embryo evaluation and application of elected euploid embryo transfers to reduce miscarriage rates, the opportunity to perform cycle segmentation, egg banking for donation and for oocyte accumulation, fertility preservation and enhancement of the cumulative live birth rate per oocyte retrieval cycle. So let's concentrate on vitrification. As already explained, the process of vitrification allows us to cryopreserve oocytes and embryos by bringing them into a glass-like state, thereby avoiding any ice crystal formation that can be detrimental to cell viability. In order to achieve high success rates, the efficiency of the vitrification program must be maintained. Indeed, according to many publications, vitrification is more effective than standard slow freezing for most stages of embryo development, resulting in doubling of pregnancy rates. Because of the high efficiency of vitrification, various commercial kits and vitrification devices are now available to IVF labs. Though they may appear different, most commercial vitrification kits have similar composition and protocols. Vitrification is a simple two-step procedure that requires the movement of cells from a cryoprotectant equilibration solution to a more concentrated vitrification solution. Here are two examples of popular protocols used successfully for embryos. The main difference between different commercial protocols is the number of vitrification solution drops that vary from 1 to 4 and the recommended volumes. The Sage vitrification kit offers flexibility to use from 0.1 to 1 ml volumes, while other kits recommend specific 20, 50, or 300 microliter volumes. Small volumes work in some hands, but safety and consistency improve with volume. Therefore, a minimum of 300 microliters is recommended, as it has proven successful with popular commercial kits. Ensure your results are satisfactory and consistent using at least a 300 microliter volume of equilibration solution before attempting to reduce volumes. Then evaluate any changes you make. The duration of exposure to the vitrification solutions must not exceed the maximum times stated in the kit's instructions for use. It's worth appreciating that volumes of the equilibration and vitrification solutions are crucial to the cryopreservation process. Here's our internal data showing the weight loss observed during the equilibration step using different volumes of solution. The blue lines represent a 15-minute equilibration of a blastocyst. As you can see, drop size will affect evaporation and consequently consistency of the environment surrounding the cells. Ideally, each cryopreservation case should be treated the same way in terms of time, volume, temperature, media, and quality, etc. This way, variation between cases and operators can be minimized and consistency in outcomes increased. Clearly, use of larger volumes will make it less likely for environmental changes to affect outcomes. There are essentially 4 commonly used permeable cryoprotectants, namely dimethyl sulfoxide or DMSO, propanediol, glycerol, and ethylene glycol, and different types of sugars used as non-permeable cryoprotectants. They appear in different variations for different purposes. For example, glycerol is mostly used in sperm freezing kits, whereas propanediol in combination with DMSO or ethylene glycol are the main components of vitrification kits. All of them do the same job, however. They drive the dehydration and rehydration processes in the cells. Despite differences in pH buffers, supplements, and slight differences in terms of the protocols, all vitrification kits have happy users and can be optimized for individual lab settings. There's still no clear evidence in favor of one or other of the cryoprotectants. However, it's important to recognize that all cryoprotectants can be toxic if used incorrectly. The warming step is one of the most important in a vitrification program. Rapid warming is crucial to avoid ice recrystallization that can be detrimental to cell survival. The warming rate is determined by two parameters: the volume and temperature of the first warming solution, which contains 1 molar extracellular cryoprotectant. The recommended volume for this step differs for different commercial kits and protocols, but is usually in the range 0.5 to 4 mils. During this step, intracellular cryoprotective agents are rapidly removed from the cells and diluted to avoid their cytotoxic effect. Therefore, this first step is very similar in different commercial kits, but the next steps can be performed either at room temperature or 37 degrees C, depending upon the manufacturer. For example, the Sage warming kit is designed for all steps to be performed at 37 degrees C, which can simplify the procedure. Nowadays, millions of oocytes and embryos are vitrified using different commercial kits. There are also a lot of cells and tissues that are still stored within cryobanks around the world that have been frozen using the slow freezing technique. Furthermore, many clinics still receive samples from other centers that were cryopreserved using different kits and different protocols. In this case, the possibility of using a universal warming protocol could simplify the management of the warming procedure. In 2014, Parmigiani and colleagues published a pilot study with encouraging results of a single universal warming protocol based on subsequent steps with 1 and 0.5 molar concentrations of extracellular cryoprotectant, irrespective of the freezing protocol of human oocytes. Such an approach could simplify lab protocols, staff training, and management of the warming procedures. In 2018, the same group from Italy published a study that assessed the clinical efficacy and efficiency of the universal warming protocol on vitrified embryos by analyzing their cryosurvival and implantation rates. This prospective randomized controlled trial was performed on 315 human blastocysts. Each embryo was randomized for vitrification using 2 different vitrification kits, Sage and Kitazato. Then, at warming, the embryos were randomly allocated to either Kitazato or Sage warming kits. The universal vitrification and warming procedures were performed for both commercial kits with slight changes. As you can see, female mean age and survival rate were statistically comparable between the study groups. The blastocyst survival rate ranges from 98.4% to 99%, and implantation rates in different groups were also comparable, ranging from 18 to 22.5%. So let's now consider the expectations, learning curve, and KPIs for the vitrification process. When implementing a new technique, we usually expect excellent outcomes. However, to get consistently good results, we should be precise and follow very clear and well-established rules. Firstly, use only good quality embryos. Then, a standard operating procedure, or SOP, for vitrification should be implemented in the clinic to ensure that all the small details have been taken into consideration. All operators, regardless of experience, should follow the SOP and a learning curve implemented. When you implement a new technique in the laboratory, what results can you expect, and how can you manage these expectations? Expectations should be balanced, and results should be comparable with fresh data. For example, you can't expect a 70% clinical pregnancy rate in vitrification cycles if the clinical pregnancy rate in fresh cycles is below 20%. Top labs are consistent and use large volumes of media. You can achieve benchmarks only when you optimize quality, experience, and consistency. Be realistic. For example, according to the Alpha Consensus meeting on cryopreservation KPIs and benchmarks, the implantation rate of human vitrified oocytes may be 10 to 30% lower than in cycles using freshly collected oocytes. According to the Alpha Consensus, predicted values for oocyte survival, fertilization, embryo development, and implantation rates all favor the vitrification technique over the slow freezing method. The implantation rate should be the same as for a comparable population of fresh embryos in the clinic, but, as stated previously, may be lower. These KPIs could be affected, nevertheless, by caseload, ovarian stimulation, and practitioner experience. For example, after analyzing 40,000 vitrified oocytes in an egg donation program in 2015, Cobo and colleagues observed differential survival rates between donors or from different stimulation cycles in the same donor, 1.4% of cycles having zero survival. The Alpha Consensus also recommended KPIs for embryo and blastocyst stage development. The expected survival rate to achieve competence and benchmarks are much higher for vitrification compared to slow freezing techniques. Overall, for the cleavage stage, it was the consensus that the benchmark for the rate of embryo development should be the same as for the comparable population of fresh embryos at the clinic, and the implantation rate should be no more than 10 to 30% relatively lower than the comparable population of fresh embryos at the center. As for the blastocyst stage, cryosurvival was defined as at least 75% of cells perceived to be intact after thawing or warming. The proportion of warmed blastocysts that re-expand within 2 hours was recommended as an extra KPI to evaluate the survival rate. Overall, for the blastocyst stage, it was the consensus that the benchmark for the rate of embryo development should be the same as for the comparable population of fresh embryos at the clinic, and the implantation rate should be no more than 10% relatively lower than the comparable population of fresh embryos at the center. To achieve the competence level and be closer or even exceed the benchmark level in vitrification, it's necessary to be consistent in all steps of the procedure and carefully manage the main parameters that can affect your results. Usually, protocols are adjusted to room temperature or to 37 degrees Celsius. However, temperature will affect the speed of the process. The normal distribution of equilibration time will be faster, for example, at 28 to 30 degrees in a warmer lab than at 20 to 22 degrees C. Hence, it's important to determine optimal timings within different laboratories by observing the mean time taken for oocytes and embryos at different stages of development to re-expand to 90% or more of their original volume after placement in equilibration solution. As previously stated, volumes are very important. Larger volumes may reduce the effect of errors. Remember that when dealing with small volumes, you increase the risk of evaporation and increased osmolality in the solution. It's better to start with large volumes during the learning phase until satisfactory results are obtained. When we implement a new technique in the lab or train a new person, we need in-house quality control procedures to assess the learning curve of trainees, as well as to monitor and optimize the introduction of a new technique. There are various methods that can be used to determine whether a trainee has reached proficiency. For example, performing a recommended number of procedures under supervision is standard practice. Alternatively, a statistical tool such as LC-CUSUM, designed to indicate when a process has reached a predefined level of performance, can be used. According to Dessol and colleagues, Vitrification procedures appeared to be easy to learn, even though the trainee was a beginner. The learning process was mostly limited by manipulation challenges. Thus, the learning curve of vitrification for a skilled embryologist is likely to be shorter, and the introduction of this technology in laboratories should be easy. Nevertheless, continuous monitoring after proficiency is required to prevent performance drift, and KPIs will help you to monitor ongoing performance. Let's now consider traceability and witnessing during the vitrification and warming procedures. As with all IVF lab procedures, correct identification of oocytes and embryos during cryopreservation is very important. Proper labeling of the cryo device with patient details such as full name, date of birth, date of freeze, and a unique identification number is crucial for the traceability of the sample. Additional information due to the specific needs of the clinic or to meet national guidelines may also be applicable. Witnessing of each step of the procedure from oocyte retrieval to placement of the vitrified sample into the cryocane assures both you and the patient that risk management during treatment cycles is being performed at the highest level. Special attention should be given to documentation of vitrified samples in cryo storage for easy identification. Both double witnessing and electronic witnessing systems can be implemented in the clinic to ensure safety of the cryopreserved sample at every step of the procedure. Here's an example of the RI Witness electronic system with a flowchart that's designed for a specific clinic to control both fresh cycles and cryopreservation of oocytes and embryos. As you can see on the diagram, it is very easy to track all data of the cycle, with embryo cryopreservation from the day of oocyte retrieval. The flowchart is fully customized for each laboratory and can be updated as the lab's SOPs evolve. Of course, identification of vitrified oocytes and embryos is very important, especially for clinics utilizing genetic testing, where it's of paramount importance to identify individual embryos. The labels or barcodes hold the identity of individual embryos, and you can see here the example of the barcode used for the RI Witness system, including all necessary information. There are different types of labels to suit various cryocarriers, such as straws, vials, and vitrification carriers. Because every cryopreserved embryo has its own individual barcode, the embryo can be easily designated according to whether it has been approved or not approved for transfer based on the genetic testing results. Naturally, RI Witness cannot automatically approve or reject the embryos. It will still be the responsibility of the lab to evaluate the genetics result and approve those embryos suitable for transfer accordingly using RI Witness. However, should anyone attempt to thaw and transfer an embryo that has not been approved for transfer, the system will provide an audio or visual alarm. Now we'll discuss a few tips and tricks that can help you to improve your results. There's still no clear evidence in terms of an optimal time for vitrification following trophectoderm biopsy. Common practice suggests that vitrification within 30 minutes of biopsy is appropriate. Most important, however, is to only start the vitrification process after cell tubing has been confirmed. It has been shown that the trophectoderm biopsy per se doesn't impair blastocyst post-warming survival and live birth rates. Finally, apply the same vitrification practice as you use in standard practice. In other words, what has been verified in your laboratory. In effect, if the blastocyst has collapsed, but you do not usually collapse, then allow it to first re-expand. On the other hand, if the blastocyst has collapsed, but you usually collapse prior to vitrification, then vitrify before the embryo re-expands. So there are many factors that should be taken into consideration to start successfully or to improve vitrification outcomes in your clinic. Firstly, only good quality oocytes and embryos should be selected for cryopreservation. You can still vitrify material of questionable quality, but don't expect the same outcomes as for good quality oocytes and embryos. Be very careful with your control of timings, temperature, osmolality, and pipetting. Evaluate the time required for equilibration, as it will differ between laboratories and stages of embryo development. For example, it usually takes less time for day 3 embryos to equilibrate compared to expanded blastocysts. Load embryos onto a carrier in minimal volumes to support an appropriate cooling rate. Be really careful with handling, transportation, and storage of vitrified specimens. And remember that the warming step is critical and reveals the sum of all prior steps, of which each may be detrimental if mistakes occur. Most current efforts are aimed at achieving a very high cooling rate using open-full straws. But publications often include some discussion of the possible contribution of the warming rate, though there have been only a couple of experimental attempts to separate the relative importance of each step. Secchi and Mazur, using the mouse model, showed the importance of the warming rate. In their experiments, the faster the warming rate, the better the survival rate. There are some tips to maintain appropriate conditions for the warming steps. Always keep the warming media at 37 degrees C and use a minimum volume of 0.5 ml. And of course, it's better to pre-warm the warming media and dish in advance and place the carrier from the liquid nitrogen into the warming solution as fast as possible. So, what can we conclude from this presentation? In summary, vitrification's a highly efficient technique for all stages of human embryo preimplantation development, from oocytes to blastocysts. Oocyte and embryo quality play a crucial role in the survival rate and clinical outcomes of vitrification protocols. The universal warming procedure can be followed regardless of the vitrification media. The warming step is as crucial as the vitrification step. Warming rate, temperature, and volume can all affect the results. Traceability and witnessing are essential to secure the success of a cryopreservation program. Initial training and ongoing competency evaluations are essential using objective KPIs. And as with any technique, the cryopreservation protocol needs to be standardized for each individual lab.